Okay, the question here says central control of breathing. Dorsal medullary and respiratory neurons associated with inspiration. Active neurons travel. Okay, let me off this one. You have to analyze all the options one by one, and then remember that they are all of the above and none of the above also in the option. Yes, answer please, so that we can move. Are you guys there? So option A. How does our medullary respiratory neurons actually control inspiration? Let's answer this one. Compliance is reduced when pulmonary venous pressure increased and lung becomes engorged with blood. Alveolar edema due to insufficiency of alveolar inflation. The lung remains unventilated for a while. Aorta nota. The keyword there is that is reduced. So when pulmonary venous pressure is increased and the lung becomes full with blood, that will actually make the lungs to become stiff and less compliant, which makes sense. Uh, then alveolar edema, of course, will also reduce compliance. When you have edema on any organ, to reduce the compliance. And the lung remains unventilated for a while. This will cause atelectasis, which will also reduce the lung compliance. So all of the above are correct. Okay, see this one. The features of a normal quiet breathing. In normal quiet breathing, the diaphragm moves downwards and ribs move downward and backward. Diaphragm upward, ribs upward and forward. Diaphragm downward, ribs upward and forward. Diaphragm upwards, ribs downward and back and backward. You can try to breathe in. Use yourself as the lab rat. Breathe in and see for yourself what it moves like. So when you breathe in, diaphragm moves downwards. Your ribs will move forward and upward. Okay, concerning surfactants, which is incorrect or false, keeps the lungs from collapsing at birth, uh, produced by type 4 alveolar epithelial cells. It's a mixture of DPPC, lipids, and protein. Deficiency can lead to infant respiratory distress syndrome. Yeah, it's option B that is off, the odd one. of the other options there are correct. In fact, that's keeping the lungs from collapsing and preventing infant respiratory distress syndrome is one of the major functions. And that's why if you get a woman that is maybe having premature rupture of membranes or premature situation, they will tend to give steroids, dexamethasone or something like that, which is supposed to stimulate the lungs of the unborn fetus to mature very faster, okay, or start producing surfactants so that the the child can survive outside. In fact, this surfactant is one of the major reasons why you put babies in ICU. So mechanism mechanism of breathing: contraction of the diaphragm rotates the lower rib in a horizontal plane. Control center is in the brainstem. Activation of the medulla leads to intercostal muscle contraction, all of the above. And then something about that surfactant, it's supposed to be, you know, the child can produce their own at 34 weeks. So that's the reason for that 34 weeks mark when you are managing all these obstetric cases. So option A is correct. When the diaphragm uh, contracts during inspiration, it will cause the ribs, like we mentioned earlier, to go upward and outward. So in that horizontal plane to increase pressure or volume in the lungs. Then option B, uh, basically breathing is regulated by the respiratory center, okay, in the brainstem. So you mentioned pulse, you mentioned medulla. Then option C, uh, the medulla contains neurons, okay, basically that control the intercostal muscles. And we know that the intercostal muscles are also the controller of breathing. So all the options are true. They are correct. So food allergy can affect the skin, maybe IgE mediated, can be caused by shellfish, all of the above, none of the above. So no need answer now. So inheritance pattern of sickle cell disease, would you say is autosomal recessive, autosomal dominant, sex linked? Sickle cell disease is so common in African countries that if anybody doesn't get this one, person should be flogged. We've answered something like this before, but let's see those who are paying attention. Following are treated with infection with parvovirus B19, splenic sequestration, aplastic crisis, acute chest syndrome. Parvovirus B19 can actually cause splenic sequestration, can cause aplastic crisis, which is the one that you guys know. And then in patients with sickle cell disease can lead to acute chest syndrome due to vaso-occlusive crisis. So it's all of the above. Following are indications of blood exchange blood transfusion except acute chest syndrome, pre-op, acute priapism, responsive to treatment, acute TIA. Okay, let's ask everybody. So the I think it's this thing responsive to treatment is the determinant for the answer. Okay. So when they say it's responsive to treatment, assuming the question says it's unresponsive to treatment, then you can now start considering maybe another option. So this question particularly relates to sickles. A lot of their complications, acute chest syndrome, TIA, priapism, can be managed with exchange blood transfusion. Like it helps in so many of those complications. Priapism, okay, but if it's already responsive to treatment, you don't need to go as far as doing an exchange blood transfusion. But if it's not responsive to other therapy, okay, the usual therapies, then you can consider that. Which is for us concerning acute chest syndrome. Results from pulmonary infarction, second most common cause of admission, commonest cause of admission, medical emergency. Yeah, you can have second and commonest at the same time. So what's the commonest cause of admission in sickle cell disease?
Crisis.
Yeah, acute chest syndrome is not that common. It's common, but like it's not the commonest. Markers of hemolysis include the following, except increased LDH, hyperbilirubinemia, increased reticulocytes, reduced LDH. Because you expect increased LDH in hemolysis. Okay. Another variation of this question. Indications for blood transfusion in a patient with sickle cell disease include the following. Indications for blood transfusion in a patient with sickle cell disease include the following, except steady state anemia, heart failure, stroke, acute chest syndrome. So what's steady state anemia?
That's the state at which the patient does not have any symptom.
Yeah, that's the HB, the hemoglobin level at which they are stable. But like they will still have anemia. It's still usually less than the normal. Maybe it's 8, maybe it's 9. Okay, so if they are at that level, you will not bother so much to start transfusing because that's their baseline, even though it's below the normal for an average person. Concerning type 1 hypersensitivity reaction, which is false, re-exposure of allergen will be presented to T cells. Degranulation of mast cells leads to vasoactive amines, can cause systemic and localized anaphylaxis, IgE mediated. In type 1 hypersensitivity, like the primary immune response is, from IgE antibodies, which are usually found in mast cells and basophils. So when the antibodies meet an antigen, it will trigger these mast cells and basophils to release um, substances like histamines and so on and so forth, serotonin. So T cells are usually not involved in type 1. They can be involved in type 4 hypersensitivity reaction. Drug-induced eosinophilic pneumonia is caused by all except penicillin, nitrofurantoin, should be chlorpropamide, and hydrochlorothiazide. Chlorpropamide is the answer. Allergic bronchopulmonary aspergillosis occurs in pulmonary TB, cystic lesion of sarcoidosis, atopic asthmatic person, immunocompromised hosts. When you read the question, even when you don't have an idea, you should be able to look for keywords. Option C. Stridor is characteristically found in tropical eosinophilia, laryngeal diphtheria, carcinoid syndrome, cardiac asthma. Option C. The other one. Okay. So laryngeal diphtheria. Anything with the larynx, stridor is usually from upper respiratory tract. While with stridor is from upper respiratory tract and it's on inspiration. So the I in stridor is for inspiration. The E in wheeze is for expiration. Wheeze comes from the lower respiratory tract. All of the following are allergic reactions to tuberculosis except few cases of pleural effusion, erythema nodosum, like tunnellar conjunctivitis, lupus vulgaris, Remember, it's an except question. Okay. Um, let's discuss with everybody. The pleural effusion is not alleged. Monophonic bronchi is classically found in chronic bronchitis, foreign body, emphysema, bronchial asthma. Wheeze and rhonchia are the same thing, but wheeze is heard without a stethoscope. Rhonchia is heard with a stethoscope. So the key word here is monophonic. So if something blocks one channel, that will likely give you a monophonic this thing. But in asthma, it's blocking here, it's blocking here, it's blocking everywhere, it's blocking everywhere. So it will give you a polyphonic, meaning it's coming from multiple places. It's B. allergic asthma, the most important mediator for pathogenesis is thromboxane A2, leukotrienes, prostaglandins, bradykinin. Which of the following drugs is not used in acute asthma? Zafelucast, terbutaline, corticosteroids, atropium, bromide.
Glucose E.
Hypersensitivity pneumonitis is due to berylliosis, bittinosis, asbestosis, bagasosis.
Sorry, Chief, what was the answer to the last question, sir?
The previous answer is Zafelucast. So, what type of hypersensitivity reaction is referred to as immune complex reaction? Of course, it's type 3. Type 1 is immediate reaction. Type 2 is antibody mediated. Type 3 is immune complex, that's antigen antibody complex. Then type 4 is delayed hypersensitivity, which is mediated by T cells. Type 1 is mediated by IgE and mast cells, histamine, and so on and so forth. Type 4 is T cells. Type 3 is antigen antibody complex and complement system. Type 2 is antibody itself. Concerning rhinitis, which is false, it is only caused by allergic reactions. It is often associated with sinusitis, may result in significant morbidity, may be complicated by conjunctivitis. This question again. Okay. Um, some few pharmacological questions before we call it a night. Grapefruit juice increases toxicity of atorvastatin, beta blockers, ethanol, carbamazepine. So find out the meanings of this two listing. Then next time we come, we'll start from here exactly. So I'll ask you the same question when we come next time. Then you tell me the answer. Just find out the meaning of these two expressions in relations to enzyme inducers, enzyme inhibitors. Okay. All right. So thanks for coming. Call it a night. See you tomorrow.
Thank you very much.
Thank you, sir. Thank you. Thank you, Chief.
You're welcome.